All right, let's go ahead and get started. Good morning. Our speaker today is Robert Aran. Our program is underwritten by an education grant through OSU Medical Center, GME. A disclosure statement has been signed and is on file in the GME office. Bob Aran is a board certified internal medicine and is the chief fellow for our gastroenterology program at Oklahoma State. He was raised in Tulsa and completed his medical training at OSU Health Science and his internal medicine at OSU Medical Center. He plans on starting his career in Tulsa after graduation at Warren Clinic Gastroenterology. The Cloud CME activity code for today's grand round is 1590. Please welcome Dr. Bob Aran.
Thank you, Dr. Cobbs, a fine young physician. Hey, everyone. My name is Bob Aran. Like he mentioned, hey, Dr. Cook, how's it going back there? It's good seeing everyone back in this room. I feel like it's been a minute since Grand Rounds kind of went through, so I'm happy to be here and see everyone. Yeah, like he said, I am a gastroenterology fellow. I graduate my fellowship program at the end of this academic year, so in June. I did my medicine training, my internal medicine training here, so I'm very familiar with what's going on around here. And I'm giving a lecture on steatotic hepatitis, several different names: hepatic steatosis, NASH, NAFLD, and MAFLD. So we'll kind of go through this and hopefully learn something. All right, disclosures and objectives slide. Everyone's got to have that. No disclosures. No one pays me anything yet. Objectives, let's just define what fatty liver disease is, differentiate between the different nomenclatures, because I'm sure you're seeing a lot of that, and it's a little confusing for some people. Identify patients with hepatic steatosis who are at high risk of developing cirrhosis, because that's really what we're trying to prevent, and understand treatments for fatty liver disease, NAFLD, NASH, etc. So I'll start with the case because every good presentation has a case. Really, this case is just going to be a scaffolding for me to kind of show things that pop up in my clinic and things that you'll probably see in your clinic also. So we'll follow around Lisa and address her questions and concerns throughout the lecture. Lisa, 55-year-old female. She has a past medical history of hypertension on one medication for this. She's been told she has pre-diabetes, but she's not on insulin or anything like that. That's how they'll usually say it. And she has reflux just like everyone else in the world. Her visit today is to establish with the primary care. So this is kind of coming from a primary care viewpoint, not necessarily a gastroenterologist viewpoint. She recently moved from Texas. She works as a lawyer for an oil company, as most people do. She was referred to you by your spouse, who's known Lisa since college, which are the best kind of patients, because those are the ones that really want to pick your brain and kind of get to know you and already have that familiarity with you because of some sort of family relationship. When she gets to your office, she has a heart rate of 82 beats per minute. Her blood pressure is 132 systolic. She's got an O2 sat of 95%. BMI is 31, excuse me. Her other labs are pretty unremarkable at first glance. White blood cell count's normal. Hemoglobin's fine. MCV is okay. Her platelets 198. That's not red, so you think that's fine also. The sodium's 136. Potassium and creatinine are within normal limits. And then we see her liver numbers, and she's got an AST of 60, an ALT of 72. She's got an ALK phos of 134 and a total bilirubin of 1, albumin of 3.4. All right, Lisa says, oh gosh, look at my liver. Does this mean I have cirrhosis? And you answer, no, I don't think you have cirrhosis. And while your liver enzymes are elevated, I think we can figure out what's happening before we see any permanent damage, right? So you want to be able to reassure a patient when you see these funny liver numbers. Maybe they saw them on their MyChart or whatever online access portal they have, and they're freaked out before they come see you. Maybe they were in an urgent care. Someone told them they have liver enzymes and they set an appointment to see you 3 months down the road. So that's really what people are worried about. Do I have cirrhosis, and is this permanent, and am I going to die? And so you, as a good doctor, you're going to start kind of the screening process of that. And like every one of us, you probably first ask, do you drink any alcohol? And so your patient's going to say no. Maybe they say they have a few cocktails. Hardly anyone's going to say, yes, I'm an alcoholic. Sometimes they'll say, no, I don't drink anything ever. And they'll be very defensive about it because you just ask them, do they have a drinking problem? Is that why their liver enzymes are up? So that's going to be a really common theme you'll see when you're in practice. So everyone's done this. Sometimes there's ER, sometimes there's surgery that comes to grand rounds. So this is kind of for them also a little bit. Surgeons deal with this as well. A lot of times it starts with a CT scan that says echogenicity changes on an ultrasound or steatosis seen on a CT. You got the CT for some other unrelated thing. And so now you got to explain to the patient what that means and what's going on. And is this chronic liver disease? Is this cirrhosis? How serious is this? Patients tend to think of liver disease as an alcohol abuse thing. I've noticed when you talk about liver disease, a lot of times you'll hear, oh yeah, my uncle or my friend's dad or someone was yellow and he died of alcohol cirrhosis or liver cirrhosis. They'll say that. So they get really nervous about this. So when you start bringing up liver disease, be gentle because they're nervous. They've seen how things can go bad. They've seen the yellow person that's walking down the street or in Walmart on the little scooter cart, and they're nervous about the whole thing. Be careful and clear with how you ask them your questions. You don't want to sound accusatory when you're asking them, do you drink alcohol? And let them know why you're asking these questions. Because a lot of times we go through our algorithm. Okay, first you check off this, then you check off that, then you check off this, and it makes sense in our head. But when you're the patient and you're getting asked those questions, it kind of feels like you're, being interrogated a little bit and like you have done something wrong. And that's not the position we want to put these patients in, right? Because they're your patients. So you want to take care of them. You want to have a good relationship with them. So let's start defining what we're talking about when we say fatty liver disease. The one I think most people have kind of defaulted to or are most familiar with is NAFLD, and that's non-alcoholic fatty liver disease. And by definition, this is the presence of hepatic steatosis, either from imaging or histology, and the absence of a secondary cause of fatty liver. All right, so excessive alcohol, we've kind of been talking about. There are other things. Hepatitis C can cause a fatty liver disease. Medications can cause a fatty liver disease. So there's a lot of other stuff that can cause it. And NAFLD is just kind of saying this is more of a metabolic issue. Fatty liver infiltration affecting at least 5% of hepatocytes with no evidence of hepatocyte injury. So does a pathologist, when they get a biopsy, actually count out 5%? Not really. Usually they can just make a ballpark estimate. They see a bunch of fat globules in the liver histology, and that's enough to call fatty liver disease. But that last line, no evidence of hepatic injury, is important. Risk factors. So you can imagine this is all going to be a metabolic issue. So your risk factors: obesity, diabetes, hypertension, polycystic ovarian syndrome, obstructive sleep apnea, maybe two that you don't think about quite as often that kind of add to this diagnosis. Age, sex, and ethnicity also play a factor. Older males higher up there, Hispanics, Native Americans, Eskimo, Caucasians, African Americans, Asians, kind of in that order, high risk for fatty liver disease also. So those are the kind of that patient population, and diabetes is up here also as one of the kind of big factors and big drivers of fatty liver disease. So NASH versus NAFLD, okay? So I mentioned that inflammation is an important part, especially when we see it on histology. So both of these are fat infiltration of the liver, but NASH is actually causing inflammation, okay? And so that's kind of difficult to diagnose from a clinical standpoint. So really, you need a biopsy to diagnose NASH. So when you're writing your notes and you're debating, do you write NASH, do you write NAFLD, what do you do? Well, to be 100% honest, you really need a biopsy to say they have NASH, right? Because we use a scoring system, and the scoring system for you isn't that important, but just so you know what we're looking at, you're looking at steatosis, so how much fat's in the liver. You're looking at ballooning, so that's hepatocyte injury, and lobular inflammation. So you're seeing these white blood cells infiltrating the liver tissue. And so you can score that, and when it's at a certain threshold, then we can start calling it NASH versus NAFLD. So the definition of NASH: the presence of necroinflammation with or without fibrosis in the background of fatty liver disease, okay? So really all you need is fatty liver disease and inflammation, and you have a diagnosis of NASH. Again, biopsy proven is typically the way to do it. Now, there's some other things that we've use. So if you've ever done a FibroSure test, well, that has this necroinflammatory score on it. And so if that's an A3, A4, are you comfortable calling that NASH? I think that would be a reasonable thing to do, especially if you've seen a quick progression through liver injury. But just so that you're all aware, this is a biopsy diagnosis. So if you're unsure, just go ahead and put NAFLD or MAFLD or one of the other things we'll talk about. And so I have definitely done that. When I've seen someone come in, new diagnosis of cirrhosis, they want us to do EGD and kind of monitor and screen them with ultrasounds. And I see that their liver enzymes have kind of gone up pretty quickly over the course of a couple of years, maybe within a decade. And now they have cirrhosis, and you've kind of followed their labs and you can kind of see a quick progression. That's probably a NASH process. So I've definitely put that in my notes for clarity, but it's a histological diagnosis. So anytime anyone gives you a lecture on fatty liver disease or hepatic steatosis, you're going to see some sort of cartoon like this. And this is really just summarizing. This came out of a Mayo Board Review book. And it's really just summarizing the clinical course and the natural history of what fatty liver disease does. And you can see at the very top there, global incidence and prevalence rate, 25%, expected to be about 33% within the close of this decade. That's a lot of people. NASH, less prevalent, but a little more serious. So 1.5% to about 6.5% for these people. The progression of fatty liver disease is you start with a healthy liver, and then you get into the NAFLD diagnosis. And NAFLD itself kind of ranges, and it's a gradient. So it's not necessarily one step forward every single time. You can have improvement based off what's happening clinically. So you end up starting with the fatty liver disease. You get fat deposits within the liver without necessarily active inflammation. Okay. And then at one point, if you're at risk for it, or if you just kind of dealt a bad hand, you start getting this active inflammation. That active inflammation is actually what's causing a lot of the hepatocyte injury and then leading into cirrhosis. And so on this scale, or on this graph, you can kind of see that there's arrows back and forth, kind of showing that there is ability to worsen and ability to improve. And that arrow back and forth even hits into cirrhosis. So back in the day, once you were cirrhotic, you're always cirrhotic. Fibrosis is permanent. What we're learning now is mild fibrosis can actually be a little bit improved if you make the appropriate lifestyle modifications. That's with fatty liver disease, and that's also with hepatitis C. So treated hepatitis C and treated fatty liver disease, you can actually get an improvement to that fibrosis score. Fibrosis, just so you know, in that top right corner, I'll kind of touch on this a little later. It's saying early NASH, F0 to F1, fibrosis with NASH, F2 to F3, and cirrhosis is F4. I'll kind of explain that a little bit later, but that's just kind of a scale of how we grade the level of fibrosis within the liver. And then alcohol-associated liver disease, right? So this is one we're all very common or familiar with, very common. When do you call it alcohol-associated liver disease, and when do you call it fatty liver disease? That's a little tricky. Everyone reacts to alcohol a little different. And there are some populations that are at a little higher risk of getting fatty liver disease or alcohol-related liver disease a little quicker than other population groups. How much alcohol does someone actually have to drink to get alcohol-related liver disease, as opposed to just they drink alcohol and they have liver disease? It's hard to tell. Really, we're talking about 3 or more drinks for men, 2 or more drinks for women, as kind of that threshold of when we're saying this is probably affecting your liver. Drinks now are classified a little differently. We're doing it by gram just because it's so variable between what a glass of wine is. Is that 5 ounces of wine? Is that a shot of vodka? Is that a beer? So that can be very variable. So now we're talking about grams of alcohol. I think that's been standardized, but no one knows what a standard drink is. If you see grams, go ahead and calculate in your head about 15 for one drink, okay? So 15 grams of alcohol. So for women, we're talking about 14 or more. For men, we're talking about about 45 to 60 grams kind of is alcohol-associated liver disease. And we typically see this over a long period of time, right? So the COVID patients that we're getting now started drinking a lot during COVID, been about 3 years. What's a lot? Yeah, maybe I have 3 or 4 glasses of wine a night. Is that really enough to have caused all their liver damage over the last 3 years? It's hard to say. And so we've come up with a new term, and the new term is MAFLD. And MAFLD is essentially taking into account that there's some alcohol role involved with the fatty liver disease. But really what it's trying to do is just classify fatty liver disease as liver presentation of a metabolic syndrome. And whether alcohol is involved or not doesn't really have that much to do with it. It's the metabolic syndrome that's driving all your disease, that constellation of symptoms, and the fatty liver disease is just the hepatic manifestation of that. So what it allows you to do is kind of bunch all those people up into one group, and you can call it a MAFLD liver disease when you're unsure how much of this is alcohol and how much of this is fatty liver disease. Now, in the primary care setting, does that really matter? Well, it kind of does, right? If you're treating someone for liver injury and you think it's because of weight, and this is all classical NAFLD, well, then you're focusing on weight prevention stuff, metabolic stuff. If you think this is all alcohol related, well, now you're talking about alcohol cessation, and are we doing some monitoring? Are we recommending AA? If you don't know, you can use something like this and touch a little bit on both. And so that's really where this comes into play. MAFLD, defined by the presence of hepatic steatosis with diabetes or obesity, or at least 2 of the minor metabolic abnormalities. And these are the same things we use when we diagnose metabolic syndrome also. So easy waist circumference, 40 for men, 34 for women, that A1C over 5.7, right? If you get to diabetes, that's diabetes, with fatty liver disease, that counts. So that pre-diabetes range, hypertension, and lipid abnormalities. So high LDL, low HDL, high triglycerides, all those would kind of count toward this diagnosis. All right. So like I mentioned, takes into account alcohol as a contribution to the disease with a constellation of other factors. And again, you can use this as kind of a catch-all for a more accurate diagnosis to give a better picture of what you're seeing. I have spent, if you got a 20-minute, 30-minute clinic appointment, are you going to spend 5 minutes like going back and forth with this person exactly how much they're drinking? Because a lot of people, maybe in college they were drinking a bunch, now they don't, or maybe they had this spell after a divorce where they were drinking a lot. And people don't want to say, oh yeah, I was definitely drinking 10 drinks per week, every week for the last, they're not going to say that. So I understand people have time limitations, and how much of that are you going to like use fighting how much they're drinking? Well, you have this diagnosis to kind of help you out with that. So another patient encounter with Lisa. All right. So she's asking, hey doc, so how bad is my liver? Right. So she had that AST, ALT in the 60s, 70s, everything else looked about okay. Maybe the platelets were dipped below 200,000, but they were still within normal range. You say, well, it depends. I don't think you're actively dying of your liver disease, but it's possible whatever damage we see is reversible also. She says, okay, great. So what comes next? Because I'm not an alcoholic, so we need to figure out the rest of this, make sure there's nothing else. And so you're going to do a big workup, and the workup for liver injury and the lecture for fatty liver disease are kind of 2 different things. But what you really need to make sure you're doing is getting a viral panel, right? Making sure people, especially in their 60s, hepatitis B, C, there's a big cohort of people there that might have hepatitis, a viral hepatitis that you didn't know about. Always check a medication list. There's a lot of medications that can cause fatty liver disease. So you really got to make sure it's not something we're doing to them. You want to start there, start with some imaging, and then you want to really check to make sure that this isn't a metabolic issue, right? And so you're going to, even if you're a liver doctor, a gastroenterologist, you should probably be checking some of these things if they're not done. An A1C, check an INR. INR is a synthetic liver lab. So you want to see, are we having synthetic issues? Platelets are another one. Albumin would be another one that you look at. You get imaging. Ultrasound's a perfectly fine place to start. Imaging is usually going to say something like mild hepatomegaly because you get a little swelling with the liver. You get an increased echogenicity because that fat echogenicity and that liver parenchyma echogenicity is different. So you see a difference of that. Usually they'll mention the common bile duct, no masses or lesions because you're worried about cancer with fatty liver disease also, because you can get HCC even without cirrhosis in the setting of fatty liver disease. And then you'll never see the pancreas because it's always obscured by intestinal gas. All right, so obesity and fatty liver disease. So NAFLD associated about 51% of patients with obesity. So if you're dealing with a patient with obesity, you really need to be looking at their liver also. NASH, people with NASH, 82% of them are also obese. So when you see these things, when you start seeing obesity, I think we're very well trained to start looking for hypertension, diabetes, but I would recommend that we're also looking for liver injury and liver disease as well. Obesity prevalence in the United States is about 40%, expected to reach about 50% by 2030, like I mentioned earlier. About 33% of these patients having metabolic syndrome. So this is only going to get worse. About 70% of individuals with type 2 diabetes are going to have NAFLD or MAFLD. And so this is the kind of the biggest group factor, or the cohort that you need to be looking at and trying to diagnose and treat. So then you obviously get a MyChart message from Lisa, and she says, "Hey doc, I was discussing our visit with my husband and he asked what my life expectancy was. We have a cruise plan for next summer and I'm wondering if I should cancel." Like I mentioned, these patients, very nervous. You have to talk to them about how bad their liver disease is. And so the best way to do that is to define it and give them some numbers, right? Because like I said, liver disease, I'm going to die of cirrhosis. That's the first thing they're worried about. So you got to kind of explain this away to them. Future-oriented patients will ask you something like this. It might not be as blunt as that about a cruise ship, but they'll ask you how bad it is. And it usually comes like a week later, and it's almost always in a MyChart message because they're thinking about it, right? They're not sleeping well. They go on Google and they're looking at, okay, liver disease. And the first thing that pops up is like cirrhotics and people with like a huge ascites, and that they don't want that, right? So what we really need to do is figure out how bad is this? And really the best way to do that is to decide, do they have NASH or do they have NAFLD? And so NASH is really what's driving the morbidity and mortality here. So finding the patients that have that inflammatory injury to the liver is going to be our goal here. NAFLD by itself can double the risk of all-cause mortality, and it's been associated with about a 6-year decrease in expected life. So in case you wanted to know, that's kind of the numbers behind that. All right, doc, I was watching Oprah and she was interviewing a liver specialist. Do you think I should go see this lady that she was interviewing? Are we missing anything? And so your answer to this is going to be kind of tough. Again, if you're in the primary care setting, how do you answer this question, right? You got someone who comes in with elevated liver enzymes. They're fine. They're not dying otherwise. They don't have cirrhosis. The ultrasound looks okay. Do you send this person to a hepatologist? Do you treat this yourself? Maybe like Lisa, she's 55 and she's due for another colonoscopy. So you have an easy out there and you can just say, why don't you go see the GI guy and you can talk about it with them. But if they're not due for a colonoscopy, what are you going to do? So the AGA, AASLD, and actually a lot of the other subspecialties, endocrine, rheum, cardiology, they kind of came out with this guidance. So this isn't guideline. This isn't like, this is guideline therapy, malpractice if you don't do it. This is guidance, and GI world is very good at that, not making a definitive guideline statement, but just giving you some tips and recommendations. And this is a new thing that came out within the last year. And so this is really aimed toward the primary care office, and it risk stratifies these patients, low, intermediate, high risk, and then it kind of gives you some ideas of what we should be doing here. And so you'll see here for low risk, we're saying this can be managed by PCP. You can bring in a dietitian, you can bring in an endocrinologist, you can bring in a cardiologist, but this doesn't necessarily have to see a liver specialist at this point. Defined by a FIB-4 score, liver imaging, stiffness measurement, or a biopsy. Lifestyle intervention, you definitely want. Weight loss, you're going to recommend weight loss on all these patients. Do you actually give a medicine for this? Not necessarily for low risk patients. Should we be looking at cardiac issues? Absolutely, on all these patients. And what do we do for their diabetes if it's there? And this at this level is just standard of care. So what are these parameters that you're looking at to see if this is a low risk patient? The first one up there is a FIB-4 score. And a FIB-4 score is an index using 4 lab values that you can just plug into your favorite calculator. I have MedCalc up here, but whatever one, there's 1,000 of these up there. So I'm not necessarily saying this is the best one, just an example, right? And so all it's looking at is age, AST, ALT, and a platelet count, right? So really factoring the age of the patient and some liver enzymes, and then it'll spit back a number at you. And the numbers you need to know, or we're kind of looking at, is 1.3 and 2.67. And if you have a value of less than 1.3, you have a 90% negative predictor value for advanced liver disease. So that is very reassuring to be able to tell a patient. If you get a value over 2.67, that's an 80% positive predictive value for advanced liver disease. Lisa, her numbers, right, the 60s, 70s, platelets were 198. Her score is a 196. So that's right there in between those two values, kind of an indeterminate or intermediate score. So that's a little harder to deal with, but we'll talk about it. I do want to point out that this uses age, obviously, as one of its numbers, and it will scale up its thought of how fibrosed or how injured the liver is based off of age, assuming that older patients have had more liver injury for a longer amount of time. Be careful with this, because if you get a young patient that is kind of on the border, so maybe they're 1.4 or they're 2.5, I kind of round that up a little bit, because I am more concerned about that young patient who's moving into advanced liver disease than I am with the 85-year-old that has advanced liver disease, right? Because the 85-year-old with advanced liver disease, they're not going to be a transplant candidate. Your options are a little more limited. So if you're dealing with a younger patient, I would say round up as opposed to just take the number at a static value. A NAFLD fibrosis score, this is just another common index or common scoring system. It's very similar to the FIB-4. You could use this just as easily. It takes a little bit more information. It factors in BMI and impaired glucose or fasting glucose or pre-diabetes. And it looks at the albumin, which is another synthetic function of the liver. So really, I like the NAFLD fibrosis score a little bit more, especially if you're worried about NASH, because it's actually looking at this kind of metabolic syndrome that we see so in concert with NASH, which is actually the thing that's causing the liver injury. Now, do you have an impaired fasting glucose? Maybe, maybe not. But I think most people are kind of getting to that level that you have it. So this is a perfectly fine scoring system. Also, a little bit more confusing. The numbers run into the negatives. So you have a NAFLD score of negative 1.45, giving you a 90% predictive value, no advanced disease, or you have a score of over 0.675 with a 96% positive predictive value of advanced liver disease. So a little more precise, a little more confusing to remember the numbers, but your calculator should tell you what it is anyway. So you don't necessarily have to memorize that. Lisa on this score is a 0.41. So again, getting up there, but not quite there. LSM, liver stiffness measurement. All right, so this is kind of new for a lot of docs. It's becoming much more popular, but it's essentially non-invasive imaging to determine liver stiffness. Thus, you're kind of estimating fibrosis, right? And so you can do this several different ways. The fanciest new way is MR elastography, where you'll actually be in an MRI machine. They'll slap a pad on you. That pad will vibrate, and the MRI will be able to pick up kind of that vibrational rebound and tell you how stiff the liver is. Shear wave elastography. This is like a setting on your ultrasound. So this is another way you can do this. So a lot of ultrasound machines will have something called shear wave elastography. You have the opportunity to pay for a program upgrade, it's usually pretty expensive, but sometimes you'll get some numbers off of a normal ultrasound. And then the vibration controlled transient elastography. So the brand name of this right now is FibroScan. And this is a dedicated device that actually, it's got its own wand. You put it up to the liver and it'll send in an ultrasound wave and watch that wave come back and estimate liver stiffness there. All these measurements are usually reported in kilopascals. They all have some variation. So whether it's 2.2 to 7, or 2 to 8, it just depends on the modality you're using. But just to give you kind of an idea, normal is less than 7 kPa. a KPA between 10 and 12, 10 and 13 is kind of that intermediate F2, F3 fibrosis. And anything over 12, we start thinking about cirrhosis and advanced liver disease. Just to give you an idea, a KPA around 20 is high risk for varices, right? So that's kind of how high these things are getting. And actually, we're using this KPA as a screening guideline if people should even be getting endoscopy also. So you may see that you may send someone with advanced liver disease to a gastroenterologist, and maybe they don't do a screening EGD, and they might cite a fibroscan as the reason why. So if your liver stiffness isn't quite up to the 20, you may see some gastroenterologists say they can wait on screening EGD. So it's becoming much more prevalent in our practice. This is an example of what a fibroscan shows. Essentially, you're taking 10 images and it's taking an average of these images. It's giving you a CAP number, which is a number that kind of estimates the fat deposits in your liver. And then it's giving you that KPA. This isn't necessarily our friend Lisa. This is just an example of what we're looking at. And a CAP value will give you anywhere between 200 and 400, less than 230, very low fat, less or greater than 270, very high deposits of fat, like 60% fat. So you can use that also to talk to your patients. This is those fibroscans are in office. So you may see some gastroenterologists do it in the office. Some primary care clinics are actually buying it. You can bill for it in case you wanted to know that. It's reading an image and you get a 5-minute procedure, can be done by your MA or your nurse, doesn't have to be done by a physician, and you get pretty good information on that. Also on that scoring system is a biopsy result. And so when we talk about biopsy, the Batts-Ludwig is kind of the most common scoring system I see. Do you need to know that as a primary care physician? No, you don't. But it's helpful to see what they're looking at. All these liver biopsies are getting a trichrome stain. Whether you got an interjugular or a transcutaneous biopsy is fine. I think the pathologists like the transcutaneous biopsies better, but we do the transjugular biopsies if we're worried about bleeding. So high INR, if you're sure this person has cirrhosis. You can also get a wedge pressure if you do it transjugularly, but a percutaneous biopsy is perfectly fine. And we're looking at perisinusoidal fibrosis or portal fibrosis as a stage 1, going up to stage 4. Stage 2 would be a fibrosis that extends beyond the portal tracts or the beginning of a bridges or septa. Stage 3 would be bridging fibrosis or septa formation. And stage 4 or cirrhosis, showing regenerative nodules, fibrous bands of the entire liver. And so what does that look like? This big picture, the vertical picture on the left is a normal liver. That trichrome stain is that blue stain you see. You can see that blue right around that portal tract, if you guys remember the portal tract from histology, and that's normal. It's supposed to look like that. That top picture on the right, though, is that F1. So you can kind of see, I don't know if you can see my cursor, how this fibrosis starts extending a little bit past that portal tract. You get into F2. This liver actually has a lot of fat deposits. So you can kind of see these fat deposits within the liver, big white circles, small white circles. That's the difference between micro and macro vesicular hepatosteatosis. And you can kind of see that you're seeing this fibrosis extending past just the portal tract. When you get to F3, you're starting to see bridging. So you're making these septa or bridges from one portal tract to another portal tract. And when you get to cirrhosis, you're starting to see regenerative nodules and the actual classical nodule-looking liver. And this is only a biopsy, so you could imagine if you expanded this out or you saw this in 3D, this fibrous band would make a complete circle. And you could see that this would make huge bridging fibrosis between normal liver. And so liver biopsy versus imaging, is it helpful? Is it not? So this is unpublished work. It's actually came out from the last AASLD, which is the big liver community in gastroenterology, essentially comparing all these images with biopsies, right? So you may wonder, all right, is the FIB-4 score actually that good? Is liver stiffness measuring actually that good? On the y-axis of all these graphs, you can see probability of survival. So that's what they're using as their endpoint here. And on the x-axis, you're seeing time in days. And you can see they all go out about 6,000 to 5,000 days. This A quadrant up here is biopsy. In red, you see F0 to F2. In green, you see F3, and F4 is in blue. And you can kind of see that these graphs line up pretty nicely between all four of these images. This A is a biopsy. Image B is FibroScan, so the vibration control. Quadrant C is the FIB4 scoring we talked about, and quadrant D is the NAFLD fibrosis scoring. And so you can kind of see they all line up pretty well. And as a GI, I'm using both the FIB4 score and liver stiffness as a really good adjuvant or proxy to a liver biopsy. And so I'm getting less and less liver biopsies. So where we really want to be, or where we really want to focus, is this intermediate and high risk liver disease. And so these are the patients that fall in that intermediate FIB4 zone that had that liver stiffness between an 8 and a 12 or higher, or you don't have a liver biopsy at all. And you can see in the high risk zone, liver biopsies start at F2. So that's someone who's already starting to have fibrosis on their biopsies. So if you happen to have that, that's the kind of patient that you really want to look at. And so what are we doing for these patients? Well, at this point, once we get to this intermediate zone, getting hepatology involved, I think, is not a bad idea. If nothing else, it gets them established with someone, but it also kind of emphasizes how serious this could be, because we want to catch NASH in active inflammation as soon as possible. We want lifestyle interventions. We want weight loss. And this is when you're really pushing them for weight loss, right? You may have this whole, hey, we should start thinking about losing weight at that low risk zone. Here's where we're really spending that time to talk to them about what we're doing, how we're losing weight, how important it is. Down at the bottom, you'll see diabetes care. And this is the patient population where we start thinking, well, if you're going to start treating diabetes, why not pick one of these other medications that have been shown to help fatty liver disease or NASH steatosis? NASH will lead to cirrhosis in about 20% of patients. That's a big number, especially when you think about how about 50% of the population is going to be obese in the next 10 years, and what percentage of those patients have fatty liver disease. And even if it's a low number, even if it's 1 to 6% of patients with NASH, overall, that's a pretty big number. So this is why this is so important. It's becoming a huge epidemic in our country. These patients also really high risk of dying of cardiovascular event. So not only do we want to identify them for the liver standpoint, but you also want to know this is the patient that's going to die of a heart attack. And typically that's how these patients die. You think of liver disease as patients dying from bleeding or maybe from infection, but really most of them are dying because of cardiac causes. NAFLD is progressing about one stage of fibrosis about every 7 years also. So you see a patient that has elevated liver enzymes in their 40s. By the time they're in their 60s, they probably progressed about 2 stages of their liver disease. So what can we do about it? Just so you know, there are no FDA approved medicines, okay? In this quarter, there are 3 or 4 stage 3 or level 3 trials that are coming out with several different medications that they're hoping to get FDA approval to treat NASH. They range from obeticholic acid. There are hormones, and FGF, I think it's 21 hormone that's coming out. There's a thyroid receptor medication that's coming out to help treat NASH cirrhosis. There are new medications on the way. None of them have been FDA approved just yet. So all these medications and everything we're talking about is off label, just so you know. Vitamin E is probably the most kind of well-known medication that was used for treating fatty liver disease. The indications are actually for people with NASH. And so this has been a hang up, I think, with a lot of gastroenterologists and a lot of primary care. Really, they were supposed to have a biopsy showing NASH before you started vitamin E treatment. Was that happening? Not really. You get some aggressive doctors, some doctors that just want to do something because they know how important this is. They were starting it without a biopsy. They saw the fatty liver disease, they started it, and I think that's perfectly reasonable. Honestly, I give it in my clinic. I think it's very reasonable to start this without a biopsy of NASH, but technically that was what the indication was for. There was some concern about the safety of vitamin E. You're supposed to be dosing it at 800 international units a day. You can go up to 1,000, but the higher you get, the higher these risk factors were. And so people were nervous about giving vitamin E for males because there's this association with prostate cancer. There's also association of higher stroke and all-cause mortality. And then there's this question whether you should be giving it with cirrhotics or with diabetic patients. And the reason they worried about that is the studies weren't done with diabetics and the studies weren't done with cirrhotic patients. So it's not that it was like contraindicated with the diabetic patients or contraindicated with the cirrhotic patients. It's that when they did most of these studies, like the Pivens trial and all these other studies with vitamin E, those patients weren't included. So off-label use, it does reduce inflammation, but it does not cure the fibrosis. And that reversal of fibrosis is really what the FDA wants to approve medicines for NASH therapy. And so a lot of these medications you've seen are actually improving the steatosis or improving the inflammation. They're just not regressing the fibrosis, which we know is possible with just exercise alone, which is why there's this kind of barrier that's been hard to break with a lot of these medications to get FDA approval. Metformin, another one that's kind of been brought up back and forth. This one actually not that helpful for improving steatosis and inflammation. So go ahead and give this to treat the diabetes. Actually, in one of the those journals they send you every month, one of those throwaways, as some of our attendings like to call them. Metformin and other diabetic medications show better outcomes with fatty liver disease, but by itself, not actually used to treat NASH or fatty liver disease. The pioglitazone actually was another medication we've been using for a long time to treat NASH, and that actually was trialed with diabetics and actually does show inflammation improvement. So that actually was a pretty good medicine, except for the fact that we're seeing that it has a lot of weight gain associated with it. So the lower doses of this medication, maybe you see less of that weight gain, but I think the medicine in general has kind of moved away from this medication, and we're moving more to those GLP-1s, those SGLT2s. And so those are kind of the newest medications people are using, really popular right now with obesity treatment because it's been approved for that. Again, not been approved for NASH just yet, but semaglutide actually is in trials to get approval for NASH treatment. New England Journal of Medicine a year or two ago had a big article looking at this, looking at the SGLT2s for cardiovascular health. And they're showing an improvement to inflammation, not necessarily an improvement to fibrosis. But I think these are the medicines we should probably be thinking about going to, especially when we're talking about cardiovascular health, right? Because some of these medications are now showing some improvement and some benefit for heart failure. And like I mentioned earlier, these patients are all dying because of cardiovascular events. So not only are you treating the inflammation of the liver, but you're hitting the biggest thing that's going to cause death, which is cardiovascular event. Statins, I say go ahead and start statins. They're not actually used for fatty liver disease. They're not indicated for that, but they are good for your cardiovascular health prevention. So go ahead and use them. They're not contraindicated. You may see a bump in LFTs when you start a statin, but that is worth it. Those will resolve in the next 3 to 6 months. So just keep an eye on it. Get labs again in 2 to 3 months. Watch it. They'll get better. And really what you're doing is you're helping their cardiovascular health, which is helping the patient's mortality and morbidity moving forward. New studies that are coming out are showing that patients that are on statins have a lower incidence of hepatocellular carcinoma. And so actually over 600 therapeutic days of high intensity statin is linked with a decrease in hepatocellular carcinoma. And when I say hepatocellular carcinoma, I'm talking about just fatty liver disease, not cirrhotics. So don't think that you have to become a cirrhotic to be at increased risk of hepatocellular carcinoma, because fatty liver disease in itself has an increased risk of hepatocellular carcinoma. So you're actually benefiting the patient by getting these patients on their medications for their cardiovascular disease. Incidence rates of hepatocellular carcinoma going up over the last 3 decades, and we're able to treat Hep C. So really they're going up because of fatty liver disease. And This is one of those diseases that you would think could be preventable with screening and with appropriate therapy. So really keep a close eye on that. NAFLD is becoming the leading cause of hepatocellular carcinoma in all developing countries. One nice thing you might be able to tell your patients, coffee might help prevent the risk of hepatocellular carcinoma. This is epidemiological studies. Am I going to say drink 2 to 3 cups of coffee and you definitely won't get cancer? No, but when you're talking about liver disease, there's not a lot of good things to say. You're telling them they can't eat. You're telling them they're going to have to exercise. They're going to have to do all this other stuff. They're worried about cirrhosis. You can at least tell them something nice, like go ahead and drink some coffee. That's good for you. So you have that in your back pocket. Touching on cirrhosis, touching on hepatocellular carcinoma, the bullet points I want everyone to kind of know about transplant. And this isn't necessarily just fatty liver disease, but just what you should know when we're talking about a patient with this, because they're going to ask you about it, I'm sure. NASH has become the leading cause of liver transplant in women and elderly. Men, alcohol still is number one, but hepatitis C has plummeted way down. And so now it's fatty liver disease. And you already know it's hard to get a liver. It's a whole process. And you're about to have a new wave of 40, 50, and 60-year-old patients that are going to need a new liver. And so things are going to be even tougher to get, more competitive to get these livers. So another reason why we should really be focused on this. The survival rate, if you get a liver transplant because of fatty liver disease, really good. First 5 years, over 80%, survival rate 10, 15 years out, 69 and 46%. The younger you are, the better you do. So early liver transplant is better than a later one. Most common causes of death after liver transplant, again, cardiovascular disease, infection, and cancer. So they're still at high risk of cancer. And just so you all know, NASH recurrence is about 20% in all these patients. And you can take a liver from an obese patient that has some evidence of hepatosteatosis, you put that liver in a skinny, doesn't have any kind of metabolic syndrome, and that liver, the fat resolves within months. Vice versa happens also. You take a liver from a very skinny person, no fat infiltration, you put that in an obese patient for, let's say, a transplant for NASH, that liver will have fat deposits within 2 or 3 months. It is definitely a systemic disease, and the person's body is what's driving this. So again, fatty liver is the hepatic manifestation of this metabolic syndrome that's going on. Simple graph just kind of showing survival probability based on age. Blue line is getting a transplant less than 55 years old. Red line getting a transplant between 55 and 65, and green line transplant after 65. And you can kind of see down at the x-axis in years, the sooner you get that liver, the better your chances of survival. Another reason you should have a close eye on these patients. And another reason when they get to be high risk, you might want to set them up with a gastroenterologist or a hepatologist so you can get them in the pipeline for a liver should they need it moving forward. Hey, Doc, good morning. Here's Lisa again. I appreciate this discussion about medications we can start for my liver disease. She's obviously been doing a lot of her own research, and she would like to try a natural approach. Apart from vitamin E, what else can I consider? Well, what are you going to tell this patient? And what you're going to tell them is they need to lose weight. And that's tough because every doctor they've ever seen since they've been 30 has been telling them to lose weight. They probably tell them that self every shred season and every bikini season or swimsuit season. So you're not really telling them anything new, but what you can tell them is maybe some specific numbers or goals to get at. More than 10% body loss, cutting calories, eating healthy. I like the Mediterranean diet, so do all the European hepatologists, and I use the CDC recommendation of over 150 minutes of working out a week, since the liver guys haven't come out with their own recommendation on that. Weight loss is going to be the most important thing. So this graph came out of a big study they did with NASH patients a couple of years ago. They looked at weight loss and how histologically their livers improved based off percentage of weight loss. And you can see they have 3 cutoffs, 5%, 7%, 10%. NASH resolution was about 10% in patients that lost 5% or less. Once you got over 7% total body weight loss, you were seeing NASH resolution in over 50%. And if you could get to over 10% body weight loss, right? That's 20 pounds in someone who's 200. That's 30 pounds in someone who's 300 pounds. 90% of these patients had NASH resolution. Fibrosis regression, 81% if you could get over 10%. Patients actually achieving total body weight loss over 10% over a year was only 10%. So this is why it's important to keep an eye on these patients. And this is why it's important to keep following these patients. Because even in a trial where people are watching you and you're accountable to other people and you have all this external motivation, only 10% of people are getting to that 10% body weight loss. But all hope isn't lost. Any weight loss you're doing is showing some improvement, okay? So you got to keep encouraging them and you got to keep trying to get them there, because steatosis improvement, even at 5 to 7%, at 65% is better than nothing, right? So don't let them get discouraged. Diet, I recommend the Mediterranean diet. The European Association of the Study of Liver Disease recommends the Mediterranean diet. It has an association with decreased hepatosteatosis, improved insulin sensitivity, and lower mortality overall. There's this stuff about wine in the Mediterranean diet we can talk about here in just a second, but that's the one I recommend since it has the most evidence-based improvement. Randomized controlled trials, shows snacking as an independent risk factor for fatty liver disease, and obviously limiting refined carbohydrates. That's a pretty easy one that I think we all can recommend. I've always liked this Lancet kind of study they did. It was back in like the 50s in regards to exercise. So getting people up and moving is important. And they had done this study on those double-decker buses, and they looked at the driver of the bus and the guy or the gal that was taking tickets and walking up and down the aisles. And back in the 50s, they even saw that the guy that was sitting driving the bus had a 3 times higher chance of having cardiovascular disease than the guy that was standing all day taking tickets. So the point of this I like is this whole standing desk revolution, getting up, walking around, getting your steps on your Fitbit, whatever it is important. And is it going to cause the 10% weight loss? Probably not. But is it good for you from a cardiovascular standpoint? Absolutely it is. And the cardiovascular reason is why most of these patients are dying anyway. So getting people up and moving is important. You want to encourage working out. Exercise alone can improve steatosis in the liver at about a rate of 20 to 30%. Now, weight loss is going to give you a higher yield. Weight loss, about 80% of these patients overall are going to have some improvement. But even if you got that guy that just really likes his IPAs, golfs a little too much, rides the cart, and isn't going to diet, get him to the gym. Do something, because you're going to get some improvement. There are no liver guidelines for working out. So like I mentioned, 150 minutes recommended by the CDC per week. Moderate exercise, trying to get your heart rate about 60% of max. That means you're breaking a sweat. That means you're not able to carry on a conversation without stopping to take a breath. And within that 150 minutes, they're recommending about 30 minutes of working out. Bariatric surgery, I think this is kind of underutilized. Fatty liver disease is not a contraindication to this. Matter of fact, pretty much all surgeons are saying, as long as they don't have portal hypertension, we'll do it. So if they meet surgical guidelines for bariatric surgery and you've done all the other stuff for that, go ahead and refer them to them if you think that they would benefit from that. Just so you know, we're moving toward Roux-en-Y's and sleeve gastrectomies, probably leaning towards sleeve gastrectomies. So if you're picking a surgeon, I would say pick a surgeon who's doing that, although most are now. And then repeat testing. So initially, if you're low risk, go ahead and repeat that FIB-4 score, that NAFLD fibrosis score in 2 to 3 years. That's based off diabetes studies that show that about 12% of patients have a 30% increase in their KPA after 3 years. So that's where that information comes from. So they have a low FIB-4 score, keep an eye on them, bring them back in 2 to 3 years and repeat that testing. Follow up on their weight loss. Your maximum weight loss is going to happen at 6 months. So if you guys are really serious about getting their weight loss down, really focus on those first 6 months. That's when they're going to get their most benefit. That's when they're going to have the most excitement about doing this. So maybe bring them back even at 3 months and do a weight check. That's the time you want to look at. There was a big weight loss trial called the AHEAD study for type 2 diabetes. Huge trial. This is like 10 years ago. 5,000 participants, which is big for GI, but this was a diabetes study. 1-hour group sessions 3 times a week. They had personal weekly trainers. This was an 8-year-long study. Meal plans given to patients, dietitians given to patients, 8 years of following these patients, and over 8 years with all the help you could possibly get, only 50% of the patients had more than 5% total body weight loss. So this is a difficult thing to do with diet and exercise. Really, really need to focus on that if this is really what we're trying to cure. Hey, doc, was thinking my mom always had stomach issues. My sister needed her gallbladder removed. Can my liver disease be genetic, and should they get screened for this? Well, what you can tell her is that there isn't any specific genetic testing, but metabolic syndrome does run in families, especially those families that don't run. And so there is some sort of genetic correlation between fatty liver disease and your family. I won't go into it too much, but the newest studies and the newest information is showing this PNPLA3 is an independent risk factor for having fatty liver disease. So even when you factor out obesity, diabetes, and cardiovascular disease, patients that are homozygous for this gene have a much higher chance of having fibrosis and having NASH. So there may be some of this in the future, but for right now, screening is for patients that are diabetic, obese, or have abnormal liver enzymes. And then at the very end, alcohol, because you're going to talk about this with your patients, a lot of our patients that drink alcohol. So people may say, well, you know, a glass of wine is good for me, and cardiovascularly, a glass of wine might be good for me, or 1 or 2 drinks probably isn't going to hurt me. A lot of this information is coming from a study that was done about 10, 20 years ago. This was a big cross-sectional study. They looked at patients from 88 to 94. They looked at 21-year-olds across all the different ethnicities you could think of, and all these people were drinking less than 2 glasses a day. And when you factored out age, sex, education, location of the country they were from, they showed that people who had a couple glasses of wine had a lower incidence rate than people who had no alcohol at all. So that's where that information came from. And really all they looked at was ALT. Did their ALT increase, wine drinkers versus non-wine drinkers? And so that's where that study came from. I'm not buying it. Really, all the new studies coming out now show that even low alcohol consumption, so averaging more than 1 drink a day, can double your risk of adverse liver-related outcomes, including death and or cancer. So once we start getting to fibrosis, once we start talking about liver disease, if you're drinking alcohol more than 1 glass a day, I can tell you that you're doubling your chance of morbidity and mortality, okay? So take-home points, wrapping up, NAFLD and NASH, spreading epidemic. This is going to be something that we're all dealing with a lot more often. You're going to start seeing a lot more cirrhosis and a lot more cirrhotic related injury because of this. NASH is really what we're looking for. It's the aggressive form of fatty liver disease, and that's really what we're trying to diagnose and treat. Evidence of advanced fibrosis should be the target population that we focus on. So just because they have elevated liver enzymes doesn't mean they're going into cirrhosis. You really want to do some of these calculations, liver stiffness measuring, to see if they're high risk or not, to focus your attention on these patients. And non-invasive testing has become the norm to risk stratify these patients. All right, that's what I got for you guys. Any questions? Dr. Cook in the back. Good seeing you again. Treating with NAC. So I am very pro treating with NAC. People that come in with an acute liver injury, I am, because a lot of times you don't know what's going on in terms of inflammation, how much of this is alcohol related, how much is it not. So if someone comes in with an acute liver injury, you're worried about them, they are showing any signs of synthetic dysfunction, so INR is going up, platelets are dropping, or any signs of hepatic encephalopathy, I'll start NAC as well as any other treatment. As a standalone, just for treatment by itself, hasn't been really recommended. It's difficult to give. Are you going to give someone like Mucomist or something over the counter? Hasn't ever been shown to actually shown any help moving forward. So I would really focus on some of these new diabetic medications. I still like vitamin E. I still like the GLP-1s and then weight loss. So as far as intermittent fasting from an obesity standpoint, I think there are some signs that it's helped a lot. And I feel like it's really helping with insulin resistance. So you're helping the patient as a whole. If that's how they're losing weight, go for it. Because really, calorie cutting is the most important thing. So even if they're having a hard time getting away from a cheeseburger, they're having a hard time getting away from prepackaged foods, if you can cut out just breakfast alone, and that's 400 to 800 calories, do that, because that might be the best we get. It's so hard to get people to lose weight. Any way you can get people to lose weight, if that's just cutting out a Coca-Cola in the morning that they were drinking, go for it. So anything that helps, go for it. The best studies, the best long-term data is with the Mediterranean diet, because it's sustainable and you don't rebound after you stop the fasting. What else? I got a couple messages, I think. Oh, maybe I don't. Can you use semaglutide with NASH diabetic patients? You absolutely can. It is not, like I said, these GLP-1s and the SGLT2s are not FDA approved to treat NASH, but they all are showing to reduce inflammation, if not stop inflammation. And so if that's the driving force of why someone's progressing in fibrosis, that's what we're trying to stop. And so these medicines do that. They haven't been shown to reverse the fibrosis like weight loss alone does. So it's much better than the alternative of not treating anything, and it's not contraindicated. So I am highly recommending doing it. The hepatologists I see that are writing some of these newer diabetic medications are the hepatologists that are also obesity medicine docs. I think a lot of the GI docs are nervous about starting these medications. They're just not familiar with them yet. The guys that are GI nutrition or obesity board certified in hepatology, those guys are using it. So if you think you should use it for weight loss or use it for diabetes, I would say go for those. All right, I'm around. Again, my name is Bob. If you have any questions, let me know. I can get you an email. And thanks for listening to me.
Great presentation, Dr. Aran. Thanks for coming to us and presenting on this important topic. So look forward to seeing you soon. Always good to see you.
You too.